Greetings. Welcome to this introduction to the U.S. healthcare system. This brief tour will orient you to the largest and most complex healthcare system in history, one which, if it were a country, would rank number 6 in size in the world. Here you see our goals for you from this video. We want you to understand the basic structure of U.S. healthcare, key historical events, reasons for high costs, performance indicators, and finally a bit about the Affordable Care Act. These points will give you a basic conceptual platform. We start with a high-level snapshot of financing and delivery. The U.S. has a mixed system with large private and public roles. On the financing side, private insurance covers a bit less than half of all healthcare. This is paid by employers and employees through premium contributions. On the public side, official programs like Medicare for the elderly and long-term disabled, Medicaid for the poor, and many other programs for specific populations pay for about 48% of care. However, the public share of financing is actually quite a bit higher than that. If we include federal government subsidies for employment-based insurance and the full cost of private insurance for government employees, then public coffers pay for nearly 2/3 of all health spending. That means we pay more per person from public funds than any other country pays in total. Out-of-pocket spending by individuals makes up the remainder. Delivery of healthcare is simpler. Providers are predominantly private. The public system provides about 1/5 of all care. Here's a more detailed look. At the top, you see the broad categories of public and private financing. Note that private includes household out-of-pocket. On the side, you see the progression from revenue collection to provision of care. Along the way, there is risk pooling, which means that collected funds are available to pay for care. Purchasing, which means the organizational structure to pay for care, and population. Let's look at the first column. This says that for Medicare, which covers the elderly and long-term disabled, revenues are collected from payroll taxes, enrollee premiums, and some other federal taxes. The money is pooled at the national level for the fee-for-service part of Medicare. The story is a little more complex than that because Medicare is often administered by private Medicare Advantage health plans, which do their own risk pooling. Finally, provision of services is mainly from private providers. You might want to consider this diagram a resource rather than light reading. And if you're a glutton for details, you could look at the national health expenditures. These are regular, detailed reports prepared by the U.S. government. You can see many different breakdowns. In this table, total health consumption spending of $2.5 trillion is made up mainly of personal health care, which is predominantly hospital care, professional services, that is, physicians mainly, and drugs, which actually have gone up sharply since this was produced for 2011. Now we look back to understand how we arrived at the current system. 3 events drove the current structure. In World War II, FDR, or Franklin Delano Roosevelt, froze wages and prices to aid the war effort. In response, employers used health insurance as a way to attract employees, hence our employment-based private health insurance. Then, in the 1960s, Lyndon Baines Johnson, or LBJ, succeeded in implementing the public system strengthening promoted by the administration of John F. Kennedy, who preceded him and, of course, was assassinated. This yielded Medicaid and Medicare. Finally, the next really big change to U.S. healthcare structure was in 2010, with the passage of Barack Obama's Affordable Care Act, which expanded both private and public components of care. Let's see these key historical events in context. On the lower left, you see medical benefits used to increase compensation during World War II. Above the line, you see Medicare and Medicaid in 1965. And finally, on the far right, you see Obama's ACA. All of the other boxes show failed attempts at national health insurance or relatively minor tweaks to the system. You can peruse this timeline at your leisure. I like to show these photos. The big picture in the upper left is LBJ signing the Medicare bill. The gentleman in the two pictures on the bottom right is Philip R. Lee, who served as the first Assistant Secretary for Health under LBJ, overseeing Medicare implementation among other responsibilities. He later created the UCSF Institute for Health Policy Studies, the first ever academic health policy unit, and my academic home. Now we look at costs. We all know this story. In 1980, the U.S. was already the biggest spender on healthcare, measured as percent of GDP, but only by a little. Over the next quarter century, we've jumped way ahead of all the other OECD countries, so that we now spend 50% more than the next country. Here's another view in dollars instead of percent of GDP. It's the same story. What's behind these costs? Careful comparisons of the US and other OECD countries identify three major factors. First is weak cost controls. Perhaps most striking in recent months is how much we pay for medications. Prescription drug prices are determined on the free market. Manufacturers can charge whatever they want. Unlike in other countries, the government does not regulate prices. In addition, while we have methods to control payments to providers, like the Resource-Based Relative Value Scale, or RBRVS, for outpatient services, they have on the whole been manipulated to the point of little effectiveness. Second, the U.S. relies much more on expensive procedures, both diagnostic, like MRIs, and therapeutic. And most doctors are specialists, which is the opposite of other OECD countries where most doctors are in primary care. And finally, a special interest of mine, administrative costs. The added administrative burden imposed by complex billing and insurance at the insurers and at the providers as well consumes more than $1 in every $8 we spend on healthcare. Let's talk a little more about administrative costs. I refer to this as billing and insurance-related administrative costs, or BIR. Here's why we spend so much on administration of payments. As you saw previously, funds come from many sources. This leads to many different payers and many different risk pools, both private and public. And this means many sets of rules and procedures that each provider must manage. This is expensive for them. This snapshot of provider BIR costs indicates the types of tasks involved. For physicians, nearly 14% of revenue goes to handling billing and insurance. Claims management and approvals consume the biggest chunk. When you consider all the BIR elements, this is what you find across the healthcare system. Clinical care is 73% of total spending. That is, less than 3/4 of the money we spend on healthcare goes to clinical care. Non-BIR administration, such as hiring and payroll, is 9% of costs. BIR administration is 18%. This includes administrative costs and profits at insurers and the BIR burden at providers. How much are we talking about? It's hard to get an intuitive handle on it. The $450 billion spent on BIR is more than $1,400 for each person in the U.S. per year. The excess amount is more than $1 billion per day and $1 trillion over 3 years. Let's turn now to system performance. Alas, we're not doing very well. Here's the percent uninsured. In other OECD countries, it's less than 1%. In the US, we've hovered at 15 to 18% for a while, depending on the exact definition. And with Obamacare, we've dropped to about 12%. In this slide, you can see insurance by poverty level. The poorest, at the left, are most likely to have public insurance, but also most likely to be uninsured. Coverage by private insurance rises with income. This slide shows that Hispanics are the most likely to be uninsured, followed by Native Americans and blacks. A nuanced look at performance on multiple indicators versus other OECD countries comes regularly from the Commonwealth Fund. As you can see, the overall US rank is 11th out of 11. We do middling on quality of care, poorly on access, and last on efficiency, equity, and healthy lives. It's also useful to examine outcomes. Compared with other OECD countries, we're worst on years of potential life lost and on infant mortality. We do a bit better in the middle of life and better than average after 80 years old. Now we'll discuss the Affordable Care Act, also widely known as Obamacare. This passed in 2010, and implementation is far along. As of this writing, the President-elect promises to dismantle Obamacare, but preserve its best elements, which is confusing. So we'll just discuss the ACA, which for the moment remains in place. Here's a little perspective on health reform. One could, in theory, rely more heavily on a free market for healthcare. Individuals to make purchasing decisions with skin in the game, in other words, money at risk. I'm not a great fan of this approach, but it has many advocates. On the other end of the spectrum is single payer, using a public fund to pay for private and public care, as in other OECD countries. This is my favorite. I think it's efficient and equitable, a truly rare combination. The ACA is in the middle, under improved mixed system, with attempts to expand and strengthen both public and private insurance. Here we see the major elements of the ACA. First, private insurance is regulated to remove some of its biggest problems. For example, under the ACA, insurance can't be taken away retrospectively due to a trivial mistake in applying for coverage. Also, everyone who applies has to be covered and charged an average community rate regardless of medical history. That's called community rating. Second, insurance exchanges are set up to facilitate shopping via structured comparisons of plans. The comparisons are helpful but incomplete. Third, means-tested public plans are increased. This has happened in about half the states. Fourth, Medicare closes some gaps in coverage, especially for drugs, and tries to rein in costs and improve quality with mixed results so far. Fifth, everyone must buy insurance. This is called an individual mandate. It is essential to preserve the financial viability of plans that must accept everyone regardless of health status, but it's very hard to enforce. Finally, the ACA provides subsidies through the tax system for exchange-based private insurance for the poor and near poor. Overall, you can see that the ACA has many moving parts, most of which are novel, and the combination is truly unique. This diagram shows the original plan for stepwise implementation of the ACA. For example, one of the first steps was ending rescission, or cancellation of coverage retroactively. The full diagram requires 4 slides. I won't take the time now to walk you through these slides, but if you want them, let me know and I can send the slides or refer you to a website. How is the ACA doing? You can see in this article from the president in JAMA, yes, he's the first president to publish in the medical literature, that we've seen decreases in uninsurance, and in the portion of privately insured individuals who could have unlimited annual out-of-pocket spending for healthcare. These are distinct gains. From my perspective, the ACA has significant problems. First, nearly 10% of the population remains uninsured. Second, those that are insured often are forced into narrow provider networks with limited or absent access to needed care. Third, administrative costs are higher than ever. Fourth, premiums are rising sharply in the exchanges, such as the 20% seen this year in California. This is probably due to the challenges of enforcing the individual mandate so that only expensive individuals enroll. Fifth, choosing the best plan, which was hard at initial enrollment, remains hard year after year as plans change and what was the cheapest plan in one year and eligible for subsidies becomes ineligible in the next year. And finally, I fear that the failings of the ACA, perhaps inevitable with such a complex Rube Goldberg contraption, risks tarnishing the potential for a more appropriate and feasible role for government, funding a simple and truly universal healthcare plan. I hope you've enjoyed this quick tour of U.S. healthcare. We'll talk soon.